Here we see an X-ray of a patient with acute exacerbation. We can see bilateral infiltrates that make us concerned for a variety of things on the differential diagnosis. We might consider pneumonia, heart failure, acute respiratory distress syndrome, aspiration, pulmonary hemorrhage, and of course, in the old days, we would call an idiopathic worsening like this an acute exacerbation. But the terminology has evolved, and I think it's important for us to think about this presentation in a broader way. Just a few years ago, a group got together and decided to reclassify and use different terminology for acute exacerbations of IPF. We now call it acute respiratory deterioration. And that's a broad category. That's an acute to subacute worsening in respiratory status with increasing dyspnea, increasing oxygen requirements, much as you saw in the case. Now, of course, there's, as I mentioned, a broad differential for that acute respiratory deterioration. In some cases, it will be extraparenchymal in origin. It could be a pulmonary embolism. It could be a pleural effusion or a pneumothorax that's occurred. So, of course, we'll do a workup to identify that. If that's the case, then we wouldn't call it an acute exacerbation. But if there's no extraparenchymal cause identified, then we'll look at the lung fields on CT. And if we see new bilateral ground glass opacities and or consolidation in that setting, if it's not otherwise fully explained by heart failure or infection, at that point, we are going to use the term acute exacerbation of IPF regardless of the cause. And that's a new twist. In the past, acute exacerbation was always idiopathic. But now we split acute exacerbation into the old idiopathic category, but also now a new triggered acute exacerbation category. And that trigger could be one of many things. Could be infection, could be drug toxicity, aspiration, could be post-procedural after a lung biopsy, for example. Now, on the other hand, if we don't see those characteristic changes on the CAT scan, then of course, it is something else. It's whatever we do see on the CAT scan. It could be pneumonia and all those other things we mentioned before. So the terminology is updated, and that's important to remember. About 10% of patients with IPF, on average, will develop an acute exacerbation in a given year. That's a pretty high percentage, and we don't understand why it happens. You know, in the triggered sense, sure, maybe it's infection, maybe it's drug toxicity, maybe it's aspiration. But in a lot of idiopathic ones where all the viral and bacterial studies are negative, it's not aspiration, and we're still trying to figure that out. You know, what are the immune pathways? What are the external exogenous triggers that might do that? What are the biological pathways inside the alveolar epithelial cells that are leading to that injury and then abnormal healing afterwards that's exacerbated in this setting? A lot to learn in that area. Clinically, it's important to think broadly about the differential diagnosis, as we talked about, and an appropriate workup would certainly include a chest X-ray that might help identify extraparenchymal or parenchymal changes, pointing us towards a diagnosis. I think maybe not immediately, but fairly shortly after this patient presents, we'd want an echocardiogram to look at LV function, valvular function, etc. And I recommend getting a CT angiogram of the chest to look for PE, while at the same time being able to look for parenchymal disease, whether it's focal consolidation suggesting pneumonia or the bilateral ground glass consolidation suggesting an acute exacerbation. PE can occur with or without those bilateral findings, of the kind of classic acute exacerbation findings on CT. And of course, a routine infectious workup is important. In the old guidelines for acute exacerbation, the recommendation was made to do bronchoscopy, but that's not feasible in most patients. So none of us should feel pressured that we always have to do bronchoscopy. If it's in a clinical setting where you think it's safe, for example, if they're on a ventilator and their FiO2 and pressures are low enough, certainly reasonable to consider, but not necessary in all cases. Let's shift to management. Management's challenging because there really are very few guidelines and there's no one standard of practice for this. I will say the mortality rate is quite high, over 50% in-hospital mortality, and even when you extend it out to 6 months or a year, it's much higher. This is not the same as your COPD exacerbation, where they're often mild or moderate and they tend to have better outcomes. Mostly it's supportive care, oxygen. I will say high flow nasal cannula oxygen has really revolutionized the management of these patients. And there are patients who we can bridge to recovery, not frequently. And sometimes we bridge them to transplant, which can be a very important therapy. Antibiotics are often used. Corticosteroids, no clinical trials ever to document that corticosteroids are helpful in the acute inpatient setting in an acute exacerbation of IPF. I will say many centers do use corticosteroids. There's no standard dosing pattern, but I do know that there are expert centers around the country that don't use corticosteroids in most cases. There's an ATS recommendation to avoid mechanical ventilation if possible. Certainly having discussions in the office long before the acute exacerbation occurs about advanced directives and your patient's wishes and preferences is ideal. That doesn't always happen. And often, and sometimes those conversations will, of course, reverse when the patient's acutely ill and does want to be on a ventilator. That's, of course, quite challenging. Older patients who are quite sick, who end up on a ventilator, have a very poor prognosis. So selecting the right patients for mechanical ventilation is important. And there are many publications with many other pharmacological agents and other therapies to treat acute exacerbations that have never been compared against placebo. There's no controlled trials. These are case series. Drugs like cyclosporin, cyclophosphamide, tacrolimus, thrombomodulin, rituximab, IVIG. People have used plasmapheresis. And even polymyxin deimmobilized fiber column hemoperfusion, mostly used in Asia, has been tried. And so whether or not these things work, we don't know. And certainly shouldn't be used in all cases. And finally, kind of one of the exciting fronts in the past few years is that there are signals that we might be able to decrease the risk of acute exacerbation. The Panther IPF trial suggested that immunosuppression might increase the risk of acute exacerbation, but we want to decrease the risk of acute exacerbation. And if we look at published data that have come from high-quality randomized clinical trials of antifibrotics, including Pirfenidone and Nintedanib, we get interesting signals. For Pirfenidone, when we do randomized comparisons between treated and untreated, we see that Pirfenidone reduces the risk of a respiratory hospitalization over the course of 1 year. That's fairly convincing data. Those are randomized comparisons. Very similar, Nintedanib seems to reduce the risk of acute exacerbation in those with more moderate to severe disease. And really, I mean the people with an FVC of 50 to 70% predicted in a subgroup analysis of that study. Those with FVC values over 70% predicted, Nintedanib did not seem to have an effect on acute exacerbation. I will say there are many, post hoc and pre-specified analyses looking at acute exacerbation with different signals, but this is encouraging. It makes sense that it might prevent exacerbation in the sicker patients. There's also data on antacids, that antacid therapy, such as proton pump inhibitors and H2 blockers, may reduce the risk of acute exacerbation. That data is really only observational in nature. There's never been, to my knowledge, a randomized trial comparing antacid therapy to placebo in IPF, but that is intriguing data. There's also, in 2018, data on the role of surgical fundoplication, and this actually was a clinical trial, randomized trial comparing surgical fundoplication to standard of care. The majority of people in both arms were on antacid therapy, and when we look at whether or not fundoplication could reduce the risk of hospitalization or death, we don't really see a significant signal. Numbers were small. Hospitalization was a secondary outcome, but the jury's, I think, still out on whether or not fundoplication might have that kind of effect.